Is that this House do now adjourn. Mr. Andrew Mitchell.
Thank you, Mr. Deputy Speaker, and may I express my thanks to Mr. Speaker for granting this adjournment debate this evening. Mr. Deputy Speaker, assisted dying is an immensely sensitive and emotive issue of conscience over which each of us individually must wrestle as members of this place, and which this House of Commons will have to address collectively before much longer. In my role as the co-chair of the all-party parliamentary group for Choice at the End of Life, which I have the pleasure of co-chairing with the Honourable Lady from Bristol South in this House, I have had discussions with many colleagues, including the Prime Minister, and I know how seriously this issue is taken. I know that many colleagues are yet to come to a firm conclusion on it. I respect that position. I respect it not least because I have completely changed my mind on this issue since I arrived in the House of Commons. This is after listening to many constituents in my office in Sutton Coldfield, often with tears of solidarity in my eyes, as they have, with inordinate sadness, told me of the painful and undignified death of someone they loved. And I have concluded, Mr. Deputy Speaker, that I want the law changed to benefit my constituents, to benefit those who I love, and possibly indeed to benefit myself. Our constituents are, according to every single opinion poll over the past 3 decades, in strong support of this change in the law. I remind the House that the bill put forward by the noble Lord Lady Meacher in the other place, which has recently commanded their lordship's support, and which builds on the consensus so painstakingly and skilfully assembled over many years by Lord Faulkner, sets out that those who are within 6 months of the end of their life, and who, in the opinion of 2 doctors and a High Court judge, have reached the decision independently and in sound mind that they wish to end their lives to avoid the often undignified and extraordinary suffering that would otherwise assail them, should they be able to do so. I will give way.
But isn't it the case that it is extremely difficult to actually assess when a life will end? Isn't this one of the challenges that we have with regard to this proposal of a timed end to a life?
Well, my honourable friend is right, but I used to be a junior social security minister, and I know that social security law means that already the government, society, has a way of determining a period 6 months before the end of someone's life. So we can, of course, reflect on this, reflect if there is a better way of doing it, but that facility does in fact already exist. Now, my aim in this... I will.
Before my honourable friend goes on, how would his bill prevent relatives or others putting pressure on the person to ask for this procedure to be put in place?
He makes a very good point, my honourable friend, and I will come directly to that later in my remarks. Now, my aim in this debate is not to persuade all colleagues of the rightness of this cause, but to make 2 clear points. First, this is a debate about the real-life consequences of our blanket ban on assisted dying, and second, the real examples from overseas of how it can be done better. In the past several days, we've seen the rules on international travel tighten once again. In the space of a week, the Swiss government closed its borders to travellers from the UK unless they undertake a quarantine of 10 days before changing the rules back a few days later. The dismay this has caused people who are seeking an assisted death in Switzerland is overwhelming. Having spent their final days confined to a hotel room, scrambling to update plans when time and energy are in such short supply, and being unable to have all or perhaps any of their loved ones there to accompany them. The already cruel situation where British citizens can have the death they want only if they travel to another country becomes yet more unacceptable when even this most exceptional option can be withdrawn with such short notice. That is not to blame Switzerland. It is the fault of our own failure as a country to provide that option at home, preferring to outsource our compassion to another country. Last year, I raised the question of travel during the pandemic with the Secretary of State for Health. He confirmed that the ban on travelling overseas did not apply to those travelling for an assisted death in another country. This announcement was a welcome relief to many, and though it once again highlights our heavy reliance on other jurisdictions to provide our own citizens with the deaths that they want. Furthermore, this I feel I might have to go a little further with my case, and then, of course, I will certainly give way. Furthermore, this leniency does nothing for those who cannot afford a trip to Switzerland, who cannot access the necessary medical records, who cannot travel due to illness or disability, or those who cannot access the services of Dignitas for a host of other reasons. And it forces all of those who accompany the dying person to break the law and run the risk of prosecution on their return. I am saddened to tell the House that David Peace has today died at Dignitas. It is a coincidence that he happened to die today. Many colleagues may have seen a touching interview with David over the summer when he spoke about the desire he had to control his death rather than let motor neurone disease choose his death for him. Earlier this week, before he left this country, his home, for Switzerland, David said this: "I have terminal motor neurone disease, a fatal illness for which there is no treatment or cure. It has robbed me of my ability to speak, swallow, balance, and walk. It is rampaging through my body, paralysing my muscles. Nothing will stop it. Palliative care cannot give me the death I want. I simply want the right to die on my own terms. My only option has been to plan an assisted death at Dignitas in Switzerland, which I have done in meticulous detail over the past few months. Though stressful and hugely expensive, this has given me comfort and peace of mind. COVID-19 measures have been a real concern throughout this year, knowing that travel restrictions or lockdowns could jeopardise my plans. The emotional and logistical nightmare I have endured over the past few days would have been avoided entirely under the assisted dying bill, which would have enabled me to go peacefully and with dignity in my own home at a time of my choosing." David's call, Mr. Deputy Speaker, is echoed by another proud Englishman, Ray Illingworth, the legendary English and Yorkshire cricketer, who was diagnosed with esophageal cancer a year ago. Talking about having to go abroad to obtain an assisted death, Ray Illingworth said this: "If that was the only option, I would, but we shouldn't have to do that. I'd like to be put to sleep in peace in my own home in Yorkshire." Ray has represented his country and is now asking his country to help him have the choice to die on his own terms. Those who cannot travel to Switzerland face only a few agonising choices here at home. For many, our world-leading palliative and end-of-life care will ensure a peaceful and dignified death. Even with the very best care, however, 17 people a day will die in excruciating pain, to say nothing for those who die with uncontrollable symptoms or without dignity in their final days. I will in just a moment. For those who wish to hasten their death, the option remains open to withdrawing life-sustaining treatment or voluntarily stopping eating and drinking with the intention of hastening death. But there is no option to take direct steps to end one's own life with medical support. Perhaps most tragic are the cases where dying people trapped in pain and despair decide to end their own lives by suicide. The best estimates are that hundreds of suicides every year are of people living with a terminal illness. I know from speaking to people who have direct experience of the loss of their loved ones to suicide that these dreadful decisions are not taken lightly, but taken as a last desperate choice due to the lack of a safeguarded assisted dying option. We must be honest about recognising the victims of our existing laws, the dozens of our citizens who feel they must travel overseas to achieve the death that's right for them, the hundreds of terminally ill people who die by their own hands, or the thousands of people who die beyond the reach of the very best end-of-life care we can offer. Every year we condemn too many people to the position of casualties of a law that lacks compassion, lacks public support, and belongs to a bygone age. I give way to my honourable friend.
I'm very grateful to him for giving way. He's making a powerful speech, as expected. And he refers to the very small number of people who he wants to give this new right to. And I recognise the extraordinary pain and distress that those individuals and those families have. But is he aware that in Oregon, which is the state that the law that's being proposed in the other place is based on, over half the people who apply for assisted death do so not because of terrible pain and suffering, but because they don't want to be a burden on their families. That's why they do it. That's what they think that is the consideration that activates them. And does he not agree that, given the, I'm afraid, the sad prevalence of abuse and neglect of elderly relatives in our own country, is likely to be replicated here. So surely the answer to the distress of people facing death is to improve palliative care, which, as he says, is excellent in this country, but it is tragically patchy and actually not good enough. And surely we should be investing significantly in palliative care, ensuring that everybody in this country has the opportunity to die with all the care that they need, which does not lead them into this terrible, distressing death, before we ever consider this terrible step of going to assisted suicide.
Yeah.
Well, my honourable friend and I will continue this argument, no doubt, for many months. And he and I are as one on the importance of improving palliative care. But alas, there are those who will never benefit because of the nature of their illness from those improvements. And in respect of Oregon, I am coming to Oregon in a moment, but to address the very point that he has made, we emphasise the importance that I'm coming to, that a High Court judge should be involved. Now, what can we learn from overseas as others like us struggle with this issue? We know this can all be done better. Indeed, with each year that passes, yet another jurisdiction takes a step forward to provide choice at the end of life for its citizens. 11 states in the USA and 5 Australian states have legalised assisted dying, with New South Wales likely to follow suit very shortly. New Zealand permits assisted dying following a nationwide referendum that found an overwhelming majority of New Zealanders supported a change in the law. In Europe, too, in the past couple of years, laws have been passed by the Spanish and Portuguese parliaments. Court judgments have overturned the bans on assisted dying in Germany and Austria. And in places like Oregon, which my honourable friend has just mentioned, assisted dying has been legal for a quarter of a century, and the eligibility criteria and processes remain essentially the same as the day they were introduced. Of the jurisdictions that have introduced assisted dying solely for people who are terminally ill and mentally competent, not a single one has subsequently extended its laws beyond that point. The other important point is the direction of travel in this area. We are told by those who oppose law change that other countries provide clear warnings of the horrors that would befall the elderly, the vulnerable, and others in society if we were to legalise assisted dying. Not only, Mr. Deputy Speaker, is there no evidence to that effect, no single jurisdiction has legalised assisted dying and then subsequently repealed that law. Do we as a House consider ourselves to be more blessed with wisdom and foresight than the parliamentarians of all these other jurisdictions, or that they have simply turned a blind eye to those concerns? The truth, of course, is that these fears, as seriously as we take them, simply have not come to fruition. Very close to our shores, change is on its way. 2 weeks ago, the States Assembly of Jersey voted by a large margin of 36 votes to 10 in support of a proposition on assisted dying, with draft legislation to be introduced by 2023. A widely signed petition led to the establishment of a citizens' jury of islanders, which found more than 75% of participants wanted to legalise assisted dying. Ireland's Parliament has given its support in principle to assisted dying in October 2020, and a new special committee has been established to begin working on legislation that will command the support of their MPs. That work will commence early next year and demonstrates the renewed commitment of the Irish Parliament to progressive causes. Perhaps most important, Mr. Deputy Speaker, is the proposed legislation in the Scottish Parliament, introduced by the long-serving and well-respected Liam MacArthur MSP. Indications are that the resulting legislation is likely to secure the support of MSPs as long as the legislation is tightly drafted and contains robust safeguards. Scotland would become the first constituent nation of the United Kingdom to legislate on assisted dying, and inevitably that may shine a light on our successive failures to progress law changes here in Westminster. I give way, of course.
Thank you very much. I thank the honourable member for giving way. He's making a very powerful speech on a highly emotive issue, and he mentioned Liam MacArthur's bill to the Scottish Parliament, which has been out, was the subject of consultation, I beg your pardon, and there is movement in Scotland. He spoke earlier of the reticence of some members, or the reluctance still to make their minds up. Does he share my hope that they will take confidence from what is happening in the Scottish Parliament and the support there and the support in the public to have the courage of their convictions if and when legislation comes before this place?
Thank the Honourable Lady very much for her intervention. And I think it must be the case and I'm sure that my honourable friend would agree with this as well, that all members of Parliament will be following what happens in Scotland with the greatest possible care, because this is an issue which, wherever you stand on the debate, it is an issue which greatly exercises members of the House of Commons. I wish to draw colleagues' attention to the process envisaged by the Scottish Parliament for a debate on this issue. A proposal has been lodged in the Parliament and the initial consultation will close in 2 weeks' time. In the new year there will be an analysis of the responses to the consultation which will feed into the drafting of the bill. Once drafted, the bill will be examined in detail by select committees calling for evidence from stakeholders across society. Only once that pre-legislative scrutiny has been completed will the legislation be debated on the floor of their Parliament. Here in this House, we lack anything like such a comprehensive system. Our system for considering private members' legislation is entirely inadequate when debating such an important issue. The government has rightly determined that it should be neutral on the principle of assisted dying, but I invite my honourable friend the Minister to recognise that neutrality on the legislative process, rather than on the principle, has the effect of siding with the status quo. A refusal to facilitate the debate is a de facto opposition to law change. Now, finally, Mr. Deputy Speaker, I would like to ask the Minister some questions about specifics of how the laws in neighbouring jurisdictions would work together. As she will no doubt be aware, the GMC, NMC and other healthcare regulators operate on a UK-wide basis. Can she confirm that if either Jersey or Scotland were to legalise assisted dying, any health and care professional who participated in and followed the requirements of that law would not face prosecution? She may also be aware that the issue of conscientious objection has previously been treated as a reserved matter by the Scottish Parliament. It should be common ground that whatever our view on assisted dying, health and care professionals should not have to actively participate in the practice if they believe it contravenes their conscience and beliefs. I understand that the government's position is that conscientious objection is in fact already within the competence of the Scottish Parliament. Can she confirm to the House that this is the case, and to what extent any legislation on conscientious objection in the Scottish Parliament would contravene the devolution settlement or require the approval of the UK government? I would like finally to ask the Minister if she can update the House on the work commissioned by the former Secretary of State, the Right Honourable Member for West Suffolk, to be undertaken by the Office of National Statistics on the number of terminally ill people who end their own lives by suicide. All of us in this House wish to tackle and reduce the number of suicides, attempted suicides and incidents of self-harm. But in order to do that, it is imperative to understand why many people take that most desperate decision. I give way.
I thank my honourable friend, the young member, for giving way, and as a fellow member of the All-Party Parliamentary Group on choice at the end of life, isn't this fundamentally about enabling everyone to have a good death, be it through the end of palliative care, if that's their wish, or by choice of having an assisted death? It is a matter of choice at the end of death. Would the member agree?
I very much agree with what the Honourable Lady has said, and she's thought about this very carefully, and all of us want to see choice extended wherever possible in our daily lives, and she's right in what she is saying. Many colleagues and former colleagues, including Lord Field of Birkenhead, have changed their mind on assisted dying, whether informed by their constituents or by their personal experience. This House is in a very different place to when this issue was last voted on more than 6 years ago. I am afraid, Mr. Deputy Speaker, that we as a House will continue to find ourselves running to catch up with the public view on this, unless a serious process for consideration of this issue is put in place. Minister?
Thank you, Mr. Deputy Speaker, and I would like to begin by thanking the Right Honourable Gentleman, the member for Sutton Coldfield, for securing a debate on this issue and for giving us time and the opportunity to outline his views on assisted dying, but also for taking many interventions on both sides of the debate. It remains the Government's view that any change to the law in this sensitive area is a matter for Parliament to decide and an issue of conscience for individual parliamentarians rather than one for government policy. I also have the utmost sympathy for all those who have suffered the pain of watching a loved one battle a life-threatening or degenerative condition, and many of us will have witnessed this, and that will inform our decisions. As he mentions, in order to develop more precise estimates of suicide risk for people with specific debilitating and terminal illnesses, the Office of National Statistics are consulting with clinical experts and are due to publish their report next year. We will consider the findings carefully when this takes place. We know this is an issue which is also being considered across the wider UK family with, as my honourable friend mentioned, an ongoing consultation in the Scottish Parliament and legislation being drafted by Jersey's Council of Ministers. We will await further details of any proposals that may be brought forward, and at which point we will be able to say more about how medical professionals can work within the different countries. The Government is, however, committed to ensuring that patients of all ages at the end of life are treated with dignity and have the opportunity to benefit from high-quality, personalised care that takes into account their wishes. The Nhs Constitution states our commitment to putting respect, dignity, compassion and care at the core of how patients are treated. And dignity means different things to different people, but as the Parliamentary and Health Service Ombudsman identified in their 2014 report, there are some key areas for ensuring dignity at the end of life. This includes enabling patient choice through appropriate care planning and promoting good and timely communication with patients and their families and between the people and organisations supporting them. We have seen many changes to the health system over the last decade, including an ambition to move more care out of acute inpatient settings and make it available to people to or closer to home. And place of care is particularly important for people at the end of life, and palliative and end-of-life care services have adapted to enable patient choice wherever possible. We know that COVID-19, the pandemic, brought new challenges with a sudden and significant increase in both the number of deaths overall and the proportion of people who passed away at home. Despite the challenging circumstances, our dedicated and exceptional palliative and end-of-life care workforce demonstrated their pragmatism and resilience and continued to provide world-class care to patients around the clock, with services working hard to adapt to meet the needs of patients, their families, and to ensure that dignity was maintained. And we are immensely grateful to them. They have truly gone above and beyond throughout the COVID response, and they deserve our unwavering support and recognition. Despite the efforts of our health and care colleagues across the system before and during the pandemic, we know there is still more that we can do. Improving the quality of care requires a confident workforce with the knowledge, skills and capability to deliver high-quality palliative and end-of-life care. And Health Education England continues to provide comprehensive training for all health and care staff involved in palliative and end-of-life care through the availability of the End-of-Life Care for All resources. Furthermore, NHS England and Improvement have committed to supporting the transformation of palliative and end-of-life care services, a point made by my honourable friend, the member for Devizes. Aligned to the long-term plan, they have developed a 3-year strategic delivery plan which prioritises the importance of improving access, quality and sustainability of these services. They are committed to providing dignified, personalised care for people at the end of their lives, including opportunities for shared decision-making conversations about their treatment and support. These conversations between healthcare professionals and patients ensure that patients' preferences and needs are taken into account when planning their care. NHS England and Improvement will be publishing Advanced Care Planning Principles in early 2022, and these will focus on the importance of providing opportunities for a person, their family or carers to engage in meaningful, person-led discussions that consider the person's priorities and preferences when nearing the end of their life. Looking forward, the Health and Care Bill presents a fantastic opportunity to strengthen the existing partnerships across the health and care system and continue the excellent work that non-statutory integrated care systems have started. NHS England and Improvement are already supporting commissioners through their strategic clinical networks. These networks are using integrated, whole-system, collaborative approaches to continue to drive improvements in outcomes for patients at the end of life, including through encouraging innovation and sharing best practice. One example is the work of the North West Palliative and End-of-Life Care Strategic Clinical Network, which is focused on delivering activities to promote equity and reduce health inequalities in palliative and end-of-life care across the region. If passed, the legislation will increase integration between health and social care further by removing barriers to data sharing and enabling joint decision-making and collaborative practice. As a government, we value collaboration at all levels, and just this morning I met with colleagues from Marie Curie to discuss services for people at the end of their life. I am keen to continue to work with our passionate and dedicated stakeholders to further consider the opportunities for embedding best practice at a local and national level, and to ensure that there is no postcode lottery or patchy services. Building on the great work already happening and looking to the future, we know that demand for palliative and end-of-life care service has increased and will continue to do so as our population ages. The Government will continue in its commitment to enable high-quality, personalised, palliative end-of-life care. And the Government is committed to ensuring dignity and choice for all, even at the most difficult of times. Thank you.
Questions that this House do now adjourn. As many say aye. Aye. No, I think the aye.